All right. Do you want me to close the door?
Okay.
Yeah?
Yeah.
Cool. All right. Sorry, Mike, did you see the first one?
Yes.
Good.
Yes.
All right, good. You're up to date. So, welcome to part 2 of Medical Terminology for Certificate 3 in Pathology Collection. All right. I did not finish that part. Sorry. Learning outcomes for today. We'll do a bit of revision for part 1 and understand some common medical terms for diseases. Now, do you remember all this? How to break down a medical term? Yeah? So it's a prefix, which is the beginning of the root word, and usually shows what's the location, the number, or maybe the time. So in this case, in hypothyroidism, hyper is excessive, that's the prefix. And the suffix is at the end of the root word to alter its meaning, often describing a procedure, condition, or disease. In hyperthyroidism, ism is condition. And then here our root word is thyroid. So excessive thyroid condition is hyperthyroidism, right? So hypothyroidism is production of too much thyroxine hormone. Guys, remember this one too? Pneumono ultramicroscopic iliovolcanic choanosis.
So what is this hyper? Because this is what I'm heading towards.
Well, which one?
Hyperthyroidism.
Yeah.
So that is my latest concern.
Yeah. Oh, like health concern?
Yeah,
No.
yeah. What is it?
It's when your thyroid hormones may be producing a bit too much thyroids.
And what happens if it's low?
If it's low, usually like like what you feel or something like that.
Yeah.
Obviously less thyroid, so you feel sluggish. You might be losing weight, I think it is as well, and your bones you can break your bones much easier because you're not getting enough calcium into your body. Thyroids also help with calcium absorption as well. Yeah, so yeah, it's very common in South Asians like us actually, unfortunately. But yeah, there's a ways around it.
And would it be called hypothyroidism?
Exactly, hypothyroidism. That's it. Very good.
Oh yeah, hyper.
Hypo and hyper, yes.
Yes.
Awesome. Now, today we're actually going to be learning about like the words we use in disease studies, or how to get about it, like in research. And disease is an illness or sickness characterized by specific signs or symptoms. So it doesn't have to be the flu. It could be like a mental health issue. It could be a broken bone as well. That's also a disease. And okay, so the reason why we're learning these words today is because in research we have our own language as well within the medical field. We need to know those properly as well. And also for you guys who are in the science industry, it will help you understand what these like big papers are talking about, and it'll help you like understand what's the real information, because there's a lot of false information going around. But if you read the right articles like Nature magazine, you'll get the right things. So instead of just throwing words at you, Latin words at you, I thought I'd just kind of give you a story with it as well. So in 2018, I think it was, I went to Papua New Guinea. I was a volunteer there. I was working on a medical ship called YWAM PNG, which is actually based out of Townsville. And basically what we did is we sailed all around Papua New Guinea to different islands. And I was a scientist on board, and we had a little lab there. And we were testing for tuberculosis over there. So today it's going to be a lot about tuberculosis and my time in PNG and the studies I did over there. So that's my hospital ship. We had about 50, 60 people on there. We had some surgeons for eye surgery, dentists as well. We couldn't do all kinds of things, but we did what we could with what we had. And of course, my main task was just tuberculosis, which was great because I think I did about 300 patients within a month. Yeah. There we go. So basically, we lived on the ship, lab was on the ship, but in the daytime, we had to go on land to collect the patient samples or help the other patients. So take our dinghies out there, visit everyone, go on the islands. So that's all of us, just getting onto the islands and welcoming everyone. So, starting off, we're going to describe the terms etiology, pathogenesis, morphology, clinical manifestations, diagnosis, prognosis, and clinical course. So we're going to break it down today with some good examples. So etiology basically means what's the cause of the disease. Now, this could be a biological agent. So in the terms of tuberculosis, it's a Mycobacterium tuberculosis. It's a bacteria. And physical causes repetitive strain. That can be if you're playing footy a lot. It could be a chemical agent. So we talk about pneumono, blah, 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 blah. That's a silicone dust disease kind of thing. So asbestos as well. And then nutritional excessive or deficiencies. So maybe not enough iodine can cause hypothyroidism. That is possible. Or too much vitamin B6. In the news lately, I don't know if you heard, people have been unfortunately taking too much B6 and they've had neurological disorders as well. So now you have to watch for that. Even if you're drinking sports drink or energy drinks, they have a lot of B6 in there. Yeah, so you can't go over 2 milligrams now.
Yeah, there is class action against black mold.
Exactly, yeah. And I was one of the people that bought the B6. I didn't know as well. Oh, and then genetic defects is also, so Down syndrome, you have an extra chromosome. That can happen too. All right, so that's etiology. So that's me over there. I'm actually on land, using one of the labs on land over there. That was a very good microscope. I was impressed. And basically, I was just checking out their slides, seeing if they were all right, doing everything. And that's basically what I see down the microscope. That is one of the slides down there. And there's no tuberculosis in that, I believe. You'll learn more about tuberculosis, don't worry. But yeah, you can see it's a pretty, not the prettiest lab.
Did you come across any cannibals there?
No.
Yeah, I heard there are.
You know, I think they're more in the more secluded islands. I was in the central province, which is where the city is, close to the city. I don't know how true that is anymore. A lot of things are just gossips and tourism stuff, I think, nowadays. So, no, I was pretty safe. I felt great over there. I hear there's a lot of pirates there as well. I did not encounter any pirates in Papua New Guinea. Oh, sorry, Anjali. I'm talking about my story in Papua New Guinea. So I'm just fusing it with their lesson as well. So yeah, as you can see, the lab's not up to date over there, but we use what we can over there. Everything's donated over there, so why not? And we give our own time as well. All right, so yes, etiology is the causes of disease. Most disease-causing agents are non-specific, so these can cause disease to a single organ or sometimes lead to other different organs, a number of organs. So tuberculosis was to the lungs, mostly that's pulmonary tuberculosis. That's what we were looking for in PNG. But sometimes it can go to the spleen, it can go to other muscles as well, and even to the heart. Most diseases are multifactorial, so they are diseases without a single cause. So maybe it's not just a bacteria, it could be a lot of other things. So these like diabetes, that's genetics and that's also lifestyle factors. So if your parents had it, you're 90% at risk of getting it as well. And then if you have a bad diet, yeah, you're definitely going to get it later in life.
Oh, don't scare me.
Yeah, us South Asians, come on, Anjali. Yeah, and so causes of disease can be split into congenital, so defects present at or before birth, so cleft lip. That happens when a mother doesn't take in enough folic acid and they'll have that split lip you'll see at birth, or maybe they might have drank alcohol as well while they had the child. They might have not known they were pregnant as well, so a lot of reasons. It could be nutritional deficiency again, or a lifestyle factor. And there's some are acquired. These are caused by events that occurs at birth or after birth. So the diseases we get now, like tuberculosis or flu, is acquired. All right, so then we have pathogenesis. It's a sequence of cellular and tissue events that take place from the time of initial contact of the etiological agent until the ultimate expression of the disease. So here we have the pathogenesis of tuberculosis. So basically, it's TB is actually airborne, like COVID, as you know. And what you get from close contact, but when someone is not wearing a mask and they're speaking directly to you. And you're going to breathe in those bacteria as well. It's in their breath as well, and their blood. And basically, that bacteria is going to go into your system, into your lungs, because that's the first passage. It's going to go to these things called macrophages, which are antibodies in your blood. And they're going to go inside those macrophages, breed. If you have a good immune system, it will go into latent mode. So it's just going to sit there and it won't get out. It won't kill the macrophage. It'll kind of make it dormant or hibernate. But let's say for any reason, it might become active because what it's going to do is going to breed and it's going to explode out and just go into other macrophages and keep doing that. And your immune system's going to go really weak. And yeah, the active disease can happen if you have HIV, so that's because you have low white blood cell count, or even if you get pregnant. Sometimes women have lower immunity when they're pregnant, so those kind of issues. So that's pathogenesis. Then morphology is the fundamental structure or form of cells or tissue. So it can be what you see, gross anatomical, what you see with your own eyes, or it can be microscopic, what you have to see through a microscope or through a tool. So here, obviously, with TB, I had to look at the bacteria through a slide. So actually, this is TB in someone's sputum. Sputum is like a phlegm you cough up in the morning. So that's what we did in the morning. We went to the islands. We're like, okay, cough up into this cup. And then I put it onto a slide, and I had to look for those little red rods right there. So that's morphology. And I did about over 300 patients. None of them had these red rods. This is like a test slide. And then you have clinical manifestations. So it explains itself. It's basically signs and symptoms someone feels from this disease. So the signs is noted by an observer, a doctor, or me, the scientist, or the nurse. It can be what you see and what you can measure. So here we can see from an x-ray, this person has TB because we can see the bacteria just killing off the tissues in the lungs and all that pus building up. So that's TB for us, or that's the first indicator of TB for us if we see it. Another sign would be in blood samples and all that, or the microscope like I was doing. That's a sign. So we saw bacteria or low immunity. And symptoms, but of course we were on a ship, we had limited supplies, we didn't have an x-ray machine, so we had to use a microscope. So, but the first way we diagnose someone was we look for their symptoms. And it's a subjective complaint, so what they're saying, that the patient is saying, what they see themselves. So are they coughing up blood? Are they having a fever? Do they have chest pain? Do they feel chills? Is their cough long term? So have they had it for more than 3 months? Do they feel really tired? Are they getting night sweats? Are they losing weight? Because with TB, they actually lose their appetite as well. So once they tell us that, we go up to them and say, okay, you know what? You're going to spit in this cup, and then we're going to come back to you to see if you have TB. So there's diagnosis. How do you find out if they have a disease or not? You get the symptoms, then you diagnose them. You do that by, a lot of things, microscope, radiology. Of course, we have the x-rays to show us that. We also have ways we call them, how do I say in a simple form? We see their antibodies or what's in their blood. In the old days, they used to do something called a Mantox test, which is where they prick your skin to see if you have the immunity. And in ACL, Australian Clinical Labs, where I used to work, we had the tuberculosis test, which you can see those 4 test tubes there. The skin test and the tuberculosis test, they just show that you have the immunity or not. They don't show if you actually have the disease. So there's actually a vaccine for TB. So if you had a vaccine as a child, but you don't know, or if you had the TB as a child and you don't know, you couldn't really tell whether you have the disease or not. So the skin test is actually being phased out now from the pathology labs because it's just lengthy. You have to come a week later and all that, and people don't like being pricked on the skin. They usually only do this when people are going overseas, like visa requirements or something like that. That one's I think $200 or $400 test as well. Again, it just shows immunity. It doesn't show if you have the disease or not, and even if it's active. Active is the one that you don't want because that's the one that actually spreads. Latent, the resting one, is the one that just sits there and you're cool as long as your immunity is good. So obviously there's different ways. We have more advanced ways now as well, biosensors. I've never used these ones at all. But then we also have multi-drug resistant TB. So that's when the antibiotics you're meant to have don't work anymore. So when your doctor's they give you a course of antibiotics to finish it all off. And if you don't, this will happen. Those bacteria that's bad for you are going to be resistant later on to that antibiotics. And then you're going to have to go on a second course and a much stronger course. And you can even be hospitalized as well. It can actually lead to death as well. So on the ship, once we diagnose someone with TB, like on the slide, we see that they actually have the TB. We then get that same sputum and we put it in a PCR machine. And what does that is it finds the TB strain and then it amplifies it, and it just checks if it's drug resistant or not. So that's how it works. So yeah, basically on the ship, all I had was my PCR machine and my microscope right there, because we're very limited. Like my lab was about just this square. That's how big it was. I had a fume hood, 2 microscopes, and that PCR machine. That was it. So we're very small.
So how do you protect yourself from the infections and contamination?
Well, it's airborne, so we just wore masks. Usually the nurses also collected the sputums as well for us, so we just the one that collected from it, just gathered it. And then it's PC2 basically, which is just mask, gloves, 70% alcohol on the area. If you wear the fume hoods if we needed it, which is what prevents the flow of the air. So yeah, it's just good practice as a scientist, PC2. Yeah. So that's me right there. When we got off the islands, we get the sputum samples. We're not allowed fire on the ship unless it's the kitchen. Our lab isn't designed for that because if it catches on fire, that's the whole ship going down.
The mask you're wearing, is it called N95?
That's
something?
right. Yeah. So that's the one we had to use.
Oh.
Yeah. So that's the advanced mask. And so basically what I'm doing there is I'm getting a little glass slide. I'm putting the sputum on there, and then I'm going to put it on fire because it has to like kill it and also like freeze it onto the slide. And then when I take it back to the ship, I go on my microscopes and I look for what bacteria I can. And it can take up to 10 to 30 minutes to find a bacteria. It depends. Like you don't want to skip anything because TB is actually a real problem there. And one of the biggest killers as well. So also those chemicals there, I'm using iodine because it'll stain the bacteria red from all the other diseases.
Why this TB thing exists there and not in Australia or New Zealand?
It exists everywhere, but it's a problem more so in PNG because one, the Medicare there or the medical system there is not the greatest. You know, like we can go to a GP and fine. These people live on islands. They don't have a doctor usually on an island, so they wouldn't know. A lot of people there, another thing is it's really hot, everyone's really close to each other, that kind of thing. And
Is it from the hygiene conditions?
that can be one factor as well. Yeah, but it's obviously it's airborne. People just stay there together in their family and they just spread it that way. Yeah, and also back in the days now it's getting better, but they used to just never treat it. These people used to just die of it and they spread it to their family members. Here we get sick, we treat it straight away. Over there, they won't know what's happening to them. That's the problem. They're very limited on their medical resources. So it's just basically getting treatment is the biggest problem. Yeah, and it's even just finding these people is really hard as well. All right, next slide. So once you got your diagnosis, you got your prognosis. So prognosis is the possible outcome and prospect of recovery from a disease. So prognosis is, I think you might hear it more in like cancer, like, oh, you have 6 months to live, or you have 5 years if you do chemo on this, or 3 months if you don't do chemo, you know, that kind of thing. But you can also have it in TB. So if you do the treatment, so you get diagnosed, you get on treatment, you have to be on the antibiotics for 6 months, you're pretty good. But if it's untreated, it's fatal. And I'll talk later about life expectancy with the prognosis. But the prognosis, so outcome of the disease, is variable. It can be due to the extent of the disease, how long you've had it for, maybe since you were a child, the delay in the treatment, the comorbidities, like what other diseases you have, your age. Obviously, if you're older, you will have less immunity, not the greatest immunity. If you need mechanical ventilation, if you need like a machine for it. Is the TB drug resistant? That can affect it too. And if you have drug reactions, that you might not be able to even take the antibiotics. Some people are allergic to that. So you can see in the picture there, those are actually TB drugs, and they have whenever somebody's diagnosed, they have to be on it for 6 months. And all this is like sponsored. It's charity, like from WHO and UN and all that, and from us guys. And basically what they made this program called DOTS. It's basically anybody who is diagnosed has to come to the clinic, and we have to see them taking the medication. They can't take it home with them because we want to make sure that they are doing this every day. It's they are able to do that. They're pretty good at it because one, they live on the island and they don't go to offices or anything like that. They live maybe an hour away, and they can come over straight away in the morning, which is great. Now, we also have the clinical course. So this is the evolution of a disease. This can also be seen as like stages. So it can be seen as acute, which is self-limiting. Acute usually means like a smaller amount of time, really. So you can see this. This is actually a, I think, myocarditis kind of evolution. So you have acute heart failure. And then you can also have chronic, which implies continuous and long-term process. You might have heard these terms with pain, like acute back pain or chronic back pain, which most of us suffers from. And then there's subacute, which can be between acute and chronic. So it can be like on and off, that kind of thing. So maybe you've had back pain for a long time, but it comes on sometimes, not all the time. But in tuberculosis, we have different. It's seen as a different way. You can have primary infection, which is when you first get it and you don't know about it. That can turn into latent, again, if you have good immunity, or it can turn to active, which can be reactivation, or post-primary TB. Again, your immunity is just bad, or you just didn't go through the treatment that well and all that. Like you just didn't take the medication every day. And I think you might have seen clinical course maybe in cancer again. You got stage 1, stage 2, stage 3, stage 4. Obviously, stage 3 and 4 is kind of the worst in cancer because that means it's gone through your body and it's going to be really hard to grab that cancer. All right. Now, more terms. We're going to be looking at epidemiology, life expectancy, morbidity, or mortality. So, epidemiology is the study of disease occurrence in a human population. It's so basically where these diseases popping up at. That's what it basically means. And it's a good thing to learn about epidemiology of the disease because it shows us what are the risk factors. How is this disease spread? Like, is this like only a family member is getting it? Maybe it's genetic. Is it just people in close quarters? Then it's airborne maybe, that kind of thing. Or maybe it's something in their food or in their water. It can also show us how to control the disease, how to prevent the disease, and how to eliminate the disease. Epidemiology looks for patterns of persons affected with a disease, including age, race, dietary habits, lifestyle, geographical location, that kind of thing. So the basis for clinical decision-making, allocation of healthcare dollars, and development of policies. It shows us where we have to spend our money, basically. Not just like throw money here, there. So this is the basically epidemiology of TB. This was in 2017, so this was around the time I was in PNG. And the darker the blue means the higher the rate of people with tuberculosis. So you can, this is PNG up here. No, sorry, up here, over here, something like that. And then South Asia, India, Africa. So they're the most affected regions. Again, for tuberculosis. As you can see, they're also considered developing nations. So these are areas that have limited health facilities and even funding as well. And then, as you go into Europe, so South America and America, it's pretty okay. So they're all right. Again, it does happen everywhere. It happens in Australia as well. It happens in Europe. And then that's closer map of PNG right there. So I was based in Central Province, which is over here. So Papua New Guinea is somewhere here. The ship does go to Western Gulf, Milne Bay, Morro Bay as well. But I was the last one there, so I wasn't given a choice, so I just stayed there in Central. As you can see, Central doesn't have much of a prevalence of TB over there, but the more rural, more outer regions away from the city do have it, like Western Province, the Gulf Province, Western New Britain as well. So again, I had 300 patients on the whole month, and none of them had TB. Again, they're near the health facilities. They can get treatment easier compared to those from the Western Province. Yeah, I've heard a lot from the Western, like they've had so many, like every third patient they diagnosed had like tuberculosis. There you go. Now, when I was talking about epidemiology, I was talking about risk factors. So what is it meant by it? Risk factors, it's like anything to do with ill health, disability, disease, or death. anything to do with that disease. It doesn't mean it's directly connected to disease, but something that's associated with it. Like maybe you're poorer, or maybe you live in the worst conditions. So they are characterized in 4 things. So one is behavioral, which is like your lifestyle. These that can be limited or reduced through lifestyle or behavioral changes. So smoking, alcohol, like cancer, of course, poor diet, diabetes, physical inactivity, excessive sun exposure, melanoma, insufficient vaccination, and sexual activity unprotected, absolutely. So behavioral is a big deal as well. Then you also have biomedical risk factors, which is a combination of genetic, lifestyle, and other broad factors. So it could be overweight and obesity, that is genetic as well. High blood pressure, high blood cholesterol, that's all genetic as well. And even impaired glucose tolerance, diabetes. Your parents had it, you can get it too. That is genetics. And then there's demographics. So it could be your age, sex, population, or subgroup. So, indigenous and all that. So this could be a woman's risk of developing breast cancer before age 75 is 1 in 11, whereas men, obviously, is 1 in 1,426. Obviously, women have breasts, but men do get it too, just at a lower rate. And I know, right? What the hell? And then there's Aboriginal and Torres Strait Islanders are more likely to die for rheumatic fever and rheumatic heart disease than other Australians. So it's something in their DNA too. And even they can't even drink alcohol because it affects them really differently. And then there's also environmental and genetic risk factors. These can be split into other subtopics as well, like social, economical, and cultural, political as well. So yes, that again, it's what's associated. It's not what's the direct cause of the disease. So you could be from a different region, and that's just like it just happens to be there. Or you can even be like people who don't have TV in their house are more susceptible to this certain disease. That is a risk factor actually, because it shows that that person might not be able to afford a TV, therefore they cannot afford the medication or afford the doctor appointments. That's what they mean by that. So it's drawing a connection basically. So you can also have, it can be genetic makeup as well. And genetics can also be split into 3. So it can be a single gene, for example, hemophilia. So hemophilia, what does that mean? Can't remember. Something to do with blood. And then fear of blood or loving of blood, something like that. And then there could be also chromosomal abnormalities. So Down syndrome, that's an extra chromosome. And it could be just multifactorial diseases, which is genetics and other factors. So diabetes, again, remember I said if your parents have it and you have a bad lifestyle, like eating habits, you're going to get diabetes. That's how it works. Type 2 diabetes, I should say, actually. Now, the risk factors for tuberculosis. The behavioral one is poor diet or alcoholism. Alcohol is kind of a big thing in Papua New Guinea, unfortunately. Smoking as well. So if they have a bad eating lifestyle and they're smoking, they're more susceptible to tuberculosis because usually their immunity is low. They don't have enough nutrition, and of course, smoking just screws up your whole body anyway. Then you have biomedical. So maybe they have HIV, so they have lower white blood cells. They could also be on medication that decreases their immunity as well. That does happen. Or they've just had other lung infections in the past that's kind of affected it as well. Demographic is the younger age group and the older age group. I couldn't find a symbol for older people, so I put a dinosaur. Sorry. I couldn't. I was looking like, this isn't good for me.
I basically waited where this was
there was a person.
so disrespectful.
I was
gonna say that's great.
I was gonna put a person in a wheelchair. I was like, well, that's just discrimination right there. I was like, which one's the worst one? So I put a dinosaur in there. I was like, someone's gonna kill me. I don't care anymore. There you go. And then for TB, we have environmental and genetic. So again, it's the location. So it's Africa and Southeast Asia and South Asia. Again, not really genetics with tuberculosis, really. Could be. Who knows? No, not really. And then we have the word life expectancy. Basically, it's the average number of years of life remaining to a person at a specific age, assuming the current age-specific mortality rates, continuing the person's lifetime. I'll get more into it, don't worry. Life expectancy can be impacted in positive or negative ways. So it can be the conditions, again, risk factors, how much of the disease have been eradicated, what conditions, also like the living conditions, and what public health campaigns, again, if they have a health center near them, like that. Negative effects on the life expectancy can be increase in certain cause of death. So AIDS, again, screws up the immunity. If they're smoking, if they have other chronic diseases like obesity. So basically, the way you'll see it, this is life expectancy. This is a graph of life expectancy. So let's say somebody gets diagnosed at 30 years old, all right? This here, the line, this solid line here is people with TB. The dotted line, or broken line, is just anybody else without TB, the background population, or that average person. So if someone's 30 years old and they're diagnosed with TB and they're not treated, they have about 12 and a half years to live. So they're by 42.5 years old, they're going to be dead.
That wasn't fair.
I know, right?
The dinosaur wasn't fair.
Yes.
I'm still stuck.
Oh, life expectancy. So yeah, basically, yeah, that's life expectancy for you. So again, you might have heard it through cancer terms. We are in a first world country. The doctor might say you have 6 months to live. I'm sorry, you know, that's life expectancy. So that's how we do it in tuberculosis. Morbidity is the condition of being diseased and the rate of disease in a population. So morbidity rate we can talk about. So in TB, in PNG, would say in 2022, 432 out of 100,000 people had TB. That's how many people had the disease of TB. That's morbidity. The mortality is the measure of death in a population. So the TB mortality in people without HIV, okay, was 44 out of 100,000 people. So the mortality over time helps us understand how health status of the population is changing. It assists us in the implementation of preventive measures. Again, it shows where we're meant to spend our money. Where do we go? So really, like, we should be going to the Western province. We shouldn't really be going to the Central province with what I was doing, because that's where it was needed. So TB is a leading cause of morbidity and mortality globally, okay? With an estimated 4,000 deaths each day. TB mortality in people without HIV, again, 44 out of 100,000 people. That's mortality. So that was TB for you. I know it's a really sad disease, but it was also a lot of fun being in PNG. Those are all my crew members there. That's Katie, my captain over there. I went to all these really nice islands. We got to sail out every day. We got to see sunsets. It was actually really nice. It was nice to see really happy people that really wanted your help, you know, compared to people here who just kind of fling shit at you when you're in the medical center. So yeah, that is your definitions of medical terms. Okay? That's it.
Good. Thank you.
All right. Thank you.